Gives me great pleasure in introducing our next speaker this morning, Dr. Dennis Gibson. Dr. Gibson went to medical school in Illinois, then did his internal medicine residency training in Florida, and then joined the faculty at the Cleveland Clinic in Florida, where he was faculty for a number of years. We at Denver Health were lucky to recruit him from Florida to Denver Health and to ACUTE a little over 4 years ago. He's been with ACUTE continuously during that time. 2 years ago was promoted to the assistant medical director of ACUTE, and more recently was deservedly promoted to the medical director position of ACUTE. Dr. Gibson's day-to-day activities, he oversees the medical care and the staff that work on the ACUTE unit. He is passionate as well about the care of our patients. He's passionate about teaching the next generation of trainees so that we increase the education about eating disorders. And without further ado, it gives me great pleasure in introducing Dr. Gibson, who will give you a talk entitled Complex Interventions When It Matters Most, a case study review. Dr. Gibson.
Thank you, Dr. Mailer. Thank you for joining us today, everybody. Nothing to disclose. Objectives. We're going to talk about the differences in the capabilities for the medical treatment of eating disorders in our unit, an inpatient medical stabilization unit, versus what you would be able to receive at an inpatient psychiatric unit or other lower levels of care. We're going to talk about several diagnoses and the medical complications of severe eating disorders that do require multidisciplinary treatment in an inpatient medical setting. And we'll analyze the integrated role of behavioral health, case management, physical therapy, and occupational therapy treatment of complex medical case disorders. So our unit is set up completely differently from any other unit in the country. Again, we're an inpatient medical stabilization unit for adolescents and adults. We have 24/7 coverage from MDs. If needed, they can be at bedside within 5 to 10 minutes if an emergent issue arises after hours, and obviously we are on the unit at all times during regular business hours. We have 24/7 nursing coverage, 24/7 bedside sitters watching the patients, making sure they're not engaging in behaviors and doing the appropriate parts of treatment. We have telemetry on our unit. This is completely different from just the intermittent EKGs that a lot of facilities can do. Again, that telemetry allows us to monitor heart rates, rhythms 24/7. We have very quick turnaround with any lab testing. Usually we get our lab results within 30 minutes up to an hour, allowing us to quickly intervene if those electrolytes are abnormal or any other lab issues requiring urgent interventions. And we have the dedicated physical therapists and occupational therapists on our unit as well that allow for very in-depth sort of bedside services that prevent them from becoming more deconditioned while they are getting the services they need. This has sort of already been discussed by Dr. Mailer's talk, but again, we specialize in every single complication that can occur with eating disorders. We know the typical appearance, we know the atypical appearance, we know when malnutrition and weight restoration is all that really needs to happen. We also know when additional workup needs to happen with these patients because their presentation is somewhat atypical compared to what we're used to seeing. We're also capable of intervening on any non-eating disorder complication, any substance abuse, intoxication, or withdrawal, alcohol intoxication or withdrawal, electrolyte derangements as discussed by Dr. Mailer, patients who have seizures or psychogenic non-epileptiform seizures, we can quickly work through to find out the correct diagnosis. Although we like to avoid it, if there is an urgent surgical need that needs to potentially be discussed, we again are able to talk with that with our colleagues. And we also take care of non-eating disorder patients with hypermetabolic conditions, one of which we'll talk about in the case series. So again, these are the 10 cases we'll go over, sort of providing why we are the right place to take care of these patients, and also providing some additional education along the way. Let's jump in. So case study 1, high medical complexity. 29-year-old female with a 13-year history of restricting anorexia nervosa presented to our unit. She had been maintaining her weights in the 70th percentile Stated her highest weight ever was about 80% ideal body weight, until very recently when she started to increasingly struggle in school, where she started losing increasing weights. About 10 days prior to our presentation at ACUTE, her parents forced her to the local emergency department, and she was admitted to the psych unit, but was quickly transferred to the medical unit due to low blood sugars. While admitted, she lost a significant amount of weight. She reported 20 plus pounds, eating only chicken broth while on the medical unit. Prior to coming in, her mother had been pureeing all of her foods and spoon feeding her. And she became incredibly deconditioned while at this unit as well, just because she was made bedridden and not allowed to do activity because of her level of malnutrition. Because of the development of her extreme bedridden state and the other medical complications, she was air ambulanced to ACUTE. Treatment history, she had been previously at residential on 2 occurrences when her eating disorder had started about 13 years prior, but otherwise she'd been followed by her outpatient team. A couple things to point out when she first arrived. Looking at her vitals, her pulse was 73, and we'll talk about the importance of that in a second. She again was very malnourished. She had lost a significant amount of weight. Our admitting weight put her at about 50% of what she should have weighed. Exam, as expected, she was very cachectic, significant sarcopenia, dry skin. Looking at her labs, white blood cells were low at 2.9, red blood cells were low at 10.5, platelets were extremely low at 12, and then looking at the next bullet point, her liver numbers, her AST and ALT were quite elevated, and her bilirubin was also quite elevated at 10. So sort of looking at the whole picture right away, the fast heart rate, the tachycardia was a bit concerning. We'll come back to this in a second. Shortly after she got to our unit, her sugars also jumped to 238. When someone is as malnourished as this patient, hypoglycemia is the expectation and the norm. You should not be seeing blood sugars of 238, so that raised a bit of a red flag and was quite concerning. The liver function tests, as I mentioned, were elevated, but the concerning part was that the bilirubin is not usually elevated secondary to the malnutrition. We'll come back to that in a second as well. And the low platelets. Gelatinous marrow transformation, basically low white blood cells, red blood cells, and platelets, again, is a frequent finding with worsening malnutrition. But usually the white blood cells and the red blood cells are significantly more affected than the platelets, and platelets of 12 are almost undetectable, so again, that was a very concerning finding. And again, 50% ideal body weight. She was extremely sarcopenic. She was unable to even lift her head off the bed upon arrival. So the tachycardia, as I mentioned, bradycardia, low heart rate is the norm. A lot of times patients will say I'm very athletic. That's the reason that my heart rate tends to be low. In an athlete's heart, you see you don't really see that significant increase in heart rate like you see with a lot of our patients. Athlete's heart rate would go from the 40s, 50s up to the 70s, 80s maybe with activity. Our patients, and what we were seeing with this patient, was that her resting heart rate was in the 70s, 80s, even 90s, 100s, and it would go up to 150, 160 with activity. So that was a very concerning sign in itself. Like I said, someone with malnutrition, body weight in the 50th percentile should be having heart rates in the 40s, 30s, 50s. Oftentimes when we see that, we start to think what additional workup needs to happen. Starvation hepatitis, like I mentioned, AST, ALT, 2 of those liver enzymes become frequently elevated as malnutrition becomes worse. It's basically the liver killing itself off, autophagy, to provide nutrients for the rest of the body. But you don't see bilirubin increases with that. So that was another red flag. We started scratching our head, what's going on with this patient. At the other facility, she had had a huge workup, all kinds of labs, tens of thousands of dollars for these sort of rare labs that were completed, all coming back unremarkable, and they were actually talking about doing a liver biopsy on this patient because they couldn't fully explain what was going on. But with starvation hepatitis, again, AST, ALT are high, bilirubin, which are also liver enzymes or liver abnormalities that can be monitored, are not elevated. Starvation hepatitis is also a predictor of low blood sugar. Again, we were seeing high blood sugar like she had had at the other facility. You're going to see that it's unremarkable. and nutrition is ultimately all that needs to happen. The Trilinear Hypoplasia, that gelatinous marrow transformation that I mentioned, leading to the low red blood cells, white blood cells, and platelets, again, in itself is not a concerning finding. It's secondary to the malnutrition, but in this patient what was very concerning was that extreme low platelets, thrombocytopenia, that was out of proportion to the white blood cells and red blood cells. So with this constellation of findings that she had already started to develop at the other hospital, and I know one of the questions with Dr. Mailer's presentation was what sets Acute apart from any hospital throughout the country, is that we sort of looked at the big picture and said this is not making sense from a malnutrition picture. She immediately had blood cultures obtained when she got to our unit, and the next day they came back positive for a gram-negative infection, which is a life-threatening infection. Immediately started on broad-spectrum antibiotics. Very lucky that this was caught, otherwise this individual probably would not be alive today. As we treated the infection and started getting her along the way, we did develop multiple other complications that we would expect to see in this individual. Phosphorus started to drop as we refed her. I know Dr. Mailer talked about this, so I won't go into the details of this, but we made sure to keep a very close eye on that and correct accordingly. Once that infection was appropriately treated, she appropriately developed low blood sugars, which we also kept a very close eye on and treated accordingly during her stay. Again, hypoglycemia is sort of the norm as you become more malnourished. You basically don't have any glycogen stores throughout the body with that level of malnutrition. And like Dr. Mailer said, this is probably a big contributor to the sudden death in this population. Immobility, again, like I said, when this individual showed up on the unit, she was incapable of even lifting her head off the bed. She required full assist to even sit at the side of the bed. She required a Hoyer lift in a wheelchair during much of her early stay. And she required nearly 6 weeks of ongoing daily physical therapy before achieving full functionality. We also have dedicated occupational therapists. When this individual first showed up, she was unable to complete.
Sorry, everyone. I guess the mic is cutting in and out, so we are going to swap mics.
Sorry about that. So again, we have dedicated occupational therapists on our unit. When she first showed up with that level of immobility, she was unable to even complete any activities of daily living. So occupational therapy worked with her on a daily basis as well to remedy that. And we also have speech and language pathology. It's not uncommon to see increasing oropharyngeal dysphagia, trouble swallowing, which can lead to aspiration pneumonia when these individuals become more and more malnourished. Summary on this patient: she presented at 50%, left at 73.4% to a residential treatment center. Functional status fully normalized, so the immobility and inability to complete ADLs was fully remedied. All of her GI symptoms were adequately controlled, and the other medical complications have been adequately addressed, and she was no longer on treatment for any of those. So again, the important bullet points: appropriate medical oversight is what you're going to get at Acute. We sort of look at the whole picture, given that we are set up with medical and behavioral providers. We're able to provide that sort of multidisciplinary care that you may not necessarily get in an inpatient psych unit. Again, we sort of know the expected presentation for all of these medical complications, and in this case, the presentation was not making sense, hence how we were able to arrive at that diagnosis of bacteremia. And last bullet point, we have dedicated PT, OT, and speech and language services that can help us to address these issues when the patients are more and more bedridden and weak. Case study 2, purging history. 35-year-old female with about a 25-year history of ANBP, heavy laxative abuse. She had been taking about 18 to 20 Bisacodyl daily. Quote-unquote hypothyroidism, asthma, low bone mineral density for age, and depression presented to our unit. She had developed her eating disorder after extensive sexual abuse at a young age, along with involvement in beauty pageants wherein she learned about purging behaviors. She had been in and out of treatment ever since her eating disorder started, really never able to maintain that adequate body weight or achieve remission. Review of systems for this patient. Will ask everyone when they arrive just very specific questions. She basically said yes to all of them, which is not an uncommon finding. So looking at this individual, sort of the concerning things that popped out, again, she was about 71% ideal body weight without any edema. Tachycardic, so her heart rate was also faster than you would expect. Pulse of 110, given her level of malnutrition. Her white blood cells, red blood cells, and platelets were actually all increased, and her other lab abnormalities were very suggestive of this pseudo-Barter picture that Dr. Mailer had mentioned previously, and her renal function was abnormal as well. Creatinine of 1.59, we often use creatinine in these individuals to look at renal function, but that is a probably poor indicator given creatinine comes from muscle mass. Given how sarcopenic and lack of muscle mass these patients are, that creatinine would be significantly higher in somebody who was at a normal body weight. So that can be a bit concerning given her level of malnutrition. Like Dr. Mailer mentioned in his talk, pseudo-Barter syndrome, normally these patients are at high risk for passing out, syncope, just because of their intravascular depletion, dehydration. The body tends to fight that by upregulating this hormone aldosterone, which is fantastic as it increases the blood pressure. However, when you start to refeed these individuals, they tend to put on huge amounts of weight, become very edematous. Treatment, you want to obviously stop the purging. That can oftentimes be very difficult, but we are quite capable of achieving that behavior intervention just because we have those 24/7 sitters. Gentle IV fluids, plus or minus potassium repletion if it's low. That helps to downregulate that increased aldosterone production. As Dr. Mailer also mentioned, we will oftentimes use spironolactone at doses of 400 milligrams daily for these patients with extensive purging history. That is not something you can do on any unit. That has to be monitored very closely when you're using doses that high just because of the potential electrolyte issues that can come with that. So this individual, even with extensive diuretic regimen, I think she did require 3 medications at one point in time. Did gain significant weight, 2.9 kilograms of weight a week, which is above our goals. Again, that is even with the perfect diuretic regimen. Oftentimes when these patients go to the ER and are given IV fluids, as Dr. Mailer had mentioned, they do develop that significant edema, contributing to worsening body dysmorphia, which then makes them want to go right back to their purging behaviors. We did improve her renal function, 0.85 creatinine at discharge, but that was still a bit higher than you would expect given her level of malnutrition. And these chronic purgers are at risk for chronic kidney disease known as hypokalemic nephropathy. We don't really know a whole lot about this. It hasn't been very well studied. We don't know how many patients develop this, but it can be a concerning thing. So that's another reason that getting these purgers to our unit to make sure they're getting the appropriate treatment is necessary. So the takeaways, again, patients with excessive or long-standing purging can develop very difficult to control weight trends, edema in the setting of pseudo-Barter. We have to watch their electrolytes and weight trends very closely, and those excessive weight trends and edema only make the psychological distress and that body dysmorphia more difficult for the patient to deal with, and it often pushes them out of treatment. So getting that appropriate treatment goes a long way. Case study 3, SMA syndrome, nutritional options. 20-year-old female with a history of ANBP, again a laxative abuse, diagnosed in 2009. She was coming to acute for worsening abdominal pain, nausea, and vomiting, although she claimed the vomiting was different than her prior purging. It was non-volitional. She had originally admitted to acute a few years back and received a diagnosis of SMA syndrome. It was diagnosed with an angle of 20 degrees and a distance of 6. Historically, 25 degrees and 8 millimeters is used as the cutoff. And indeed, narrowing of that third part of the duodenum. I'll show some pictures again to explain this in a second. She was initiated on tube feeds, transitioned to all orals by the time of discharge to a residential treatment center, achieving about 90% ideal body weight while at the facility. However, increasing stressors several months thereafter led to restriction and weight loss. So she presented to an outside hospital, received a recommendation to undergo small intestinal bypass because of that SMA syndrome. However, again, surgery is never recommended for SMA syndrome, and her symptoms gradually returned over the ensuing year. Again, upon arrival to our unit, she denied any actual volitional purging behaviors. Vitals, she was about 61% ideal body weight, the low heart rate and the low blood pressure to be expected. On exam, she did have diffuse tenderness to deep palpation of her abdomen, no edema. Potassium was quite low, which is also what you would expect to see in somebody who has that purging behavior. So SMA syndrome, I know you saw this picture in Dr. Mailer's presentation, but basically with ongoing weight loss, you start to lose that fat pad, that mesenteric fat that pushes the SMA artery apart from the aorta, your main blood vessel. And as you do so, you compress that first part of the intestine, making it hard for food to get through and leading to backup of food into the stomach, leading to the stomach symptoms that are reported, as well as nausea and oftentimes vomiting. Here's another picture. That picture on the left showing that angle, and then that picture on the right showing that small black line is basically the compressed small intestine. Here's another picture. This is not the patient that we were dealing with, but a good picture of basically complete compression of that first part of the small intestine. You can see where that arrow is pointing that basically there is abrupt cutoff of any contrast getting through, showing again that there's significant compression there. Treatment, weight restoration is what ultimately needs to happen. We actually did a case series about a year or so ago in our unit. Patients anywhere in the range of 50% ideal body weight up to about 70% ideal body weight on presentation. Strictly weight restored, no surgical recommendations completed. Symptoms were nearly resolved, if not fully resolved, with solely that nutritional rehab. This question also sort of goes back to that question from Dr. Mailer's presentation. Patients, when they go to these non-eating disorder specific facilities, oftentimes get surgical interventions that are unwarranted. Again, this surgery for this SMA syndrome did not actually relieve her symptoms. Another example, we've had a young girl present to us before after receiving a pacemaker for significant low heart rate. We actually called that facility multiple times saying this is wrong, don't do this, she needs weight restoration. Cardiologist refused to listen to us. Poor girl had a pacemaker placed and then she had a collapsed lung as a complication of that procedure. So again, we know when surgical intervention is warranted, we know when surgical intervention is the wrong way to go. These are just sort of two instances where surgery was not the right way to go. When it comes to nutritional options for SMA syndrome, we can do whatever intervention is necessary. Oftentimes we will first try just a liquid diet. Again, the liquid is easier for the stomach to digest to get past that compressed part of the first intestine. If we're not able to do that, still having significant symptoms, vomiting, we will place a feeding tube that bypasses that obstruction. In rare instances, when that also we're not able to bypass that obstruction and the patient is incredibly symptomatic vomiting, we can place IV and do nutrition through that route if we absolutely need to, although we rarely have to go that route. So the summary in this case, we did place a feeding tube. Again, she presented at about 61% ideal body weight. She was discharged at about 70.5% ideal body weight. Symptoms had nearly resolved at that point in time, and she was completely tolerant of 100% PO by the time she was discharged, so able to fully get her off that tube feed. So takeaways again, surgical versus medical treatment options. These sort of cases, medical treatment is the route that needs to happen. Surgery is not appropriate for SMA syndrome. We are quickly able to obtain radiologic testing. If the patient has concerning symptoms for SMA syndrome, we can get that CAT scan or upper barium swallow study completed within an hour or two. And then we have the ability to provide nutrition in whatever route is necessary to get that SMA syndrome better. Case study 4, atypical anorexia nervosa. So 18-year-old male with a history of disordered eating since childhood, reaching a maximum weight of 410 pounds at age 15. Approximately 6 months ago, he had lost about 180 pounds, weighing 230 pounds, and was advised by a medical professional to continue weight loss, limiting his intake to 1,600 calories. Because of that significant restriction, he started to experience binging without purging. He was admitted to an outside PHP 3 days prior to coming to us, but was found to be symptomatically hypoglycemic with a blood sugar of 40. hence he was transferred to the local ER where he was started on IV dextrose. Came to us 3 days later, having gained 10 pounds at that outside hospital. Vitals, again, he was above 100% ideal body weight, but given that extent of weight loss, this hypoglycemia is not unexpected. And again, he had a little bit of liver numbers abnormalities consistent with starvation hepatitis, and his blood counts were low, consistent with that gelatinous marrow transformation. And even, the fourth day after originally presenting to that PHP and getting IV dextrose and nutrition at the outside facility, he continued to have low blood sugars with a glucose of 49. So kind of like Dr. Mailer had mentioned in his talk as well, the medical complications of atypical anorexia are more similar than different compared to anorexia nervosa. We don't know a lot of those medical parameters and complications at this point in time. They have not been adequately studied. But what we do know, the physiologic changes, that the extent of weight loss does predict low heart rate, and it does predict low blood pressure. It predicts changes with thyroid hormones, growth hormones, and luteinizing hormone, which is one of those main sex hormones leading to testosterone and estrogen production. And it actually portends a worse outcome because a lot of times, given their higher body weight, a lot of providers think this patient is not at significantly increased risk for medical complications, which is, again, not true. They're at just as much the same risk as those at lower body weights. And there actually seem to be at maybe worse psychological outcomes as well. So these patients definitely still need our help. So this patient, 4 days into our admission, was still having ongoing low blood sugars less than 60. So we're talking now a week into treatment. The Trilinear Hypoplasia, that gelatinous marrow transformation, again, not well studied in atypical anorexia, but seems to suggest correlation with extent of weight loss. And hypophosphatemia, the studies are somewhat inconclusive, but our sort of subjective experience, or objective experience, I guess, suggests that these patients are at just as much a risk for hypophosphatemia, oftentimes actually requiring IV phosphorus, than patients that are not atypical anorexia as well. So not only the low blood sugars, but the low phosphorus, very concerning and need very close intervention and monitoring, or else these patients are at high risk for morbidity and mortality. So takeaways from this case, higher weight patients with aggressive weight loss also benefit from our medical oversight. If this patient had first come to us, we would have not started that IV dextrose. We would have started tube feeds. As Dr. Mailer had mentioned, sometimes when you place that IV, you can get a paradoxical worsening of their low blood sugars. And again, not just the low blood sugars, but other physiologic changes and electrolyte issues can come along with this significant amount of weight loss. Case study 5, Ehlers-Danlos. So 34-year-old male with Ehlers-Danlos syndrome, diagnosed via genetic testing, associated with symptoms of constipation, gastroparesis, indeed was found to have a positive gastric emptying study, anxiety, depression, frequent joint dislocations, and temporomandibular joint disruptions, so the jaw having a lot of pain as they eat, presenting at 64.7% ideal body weight, with significant decompensation since COVID began. The GI symptoms were the biggest contributor to the increasing weight loss. Also reported symptoms of severe GERD, reflux, contributing to the dysphagia, trouble swallowing, as well as, again, those worsening jaw symptoms. Although he had Botox injection about 3 days prior to coming to our unit, that was further contributing to the difficulty chewing. So Ehlers-Danlos is not something that's very well studied at this point in time. It seems to be one of those areas that's somewhat developing. I can think off the top of my head, there's only a handful of articles that have really been in studies that have been completed looking at Ehlers-Danlos as it pertains to eating disorders. But again, it is becoming more and more frequent, and we are seeing a lot more of these patients on the unit. So Ehlers-Danlos is associated with a constellation of GI symptoms. These patients do have a very high frequency of delayed gastric emptying, that gastroparesis. One study reported as high as almost 3/4 of patients having that gastroparesis. There's a very high prevalence of functional symptoms as well. So irritable bowel syndrome, which, as we know, can be very difficult to sort of feed through, along with the GI symptoms present just from the malnutrition. There's oftentimes smell and taste abnormalities present with Ehlers-Danlos that further contributes to the difficulty with weight restoration. Autonomic dysfunction is a very common feature in this population that further leads to that syncope, passing out, and orthostasis, low blood pressure that we see in this population. And what makes Ehlers-Danlos very difficult is that diagnosis is really, there's clinical criteria, but to truly make the diagnosis, you need genetic testing. And the genetic variant most commonly tied to eating disorders does not have a genetic test yet available. We don't know that genetic variant that leads to it. So it can sometimes be difficult if a patient says, I have Ehlers-Danlos syndrome. It can sometimes be very difficult to separate out the eating disorder from the Ehlers-Danlos without that genetic test. As I mentioned, there are several case reports describing Ehlers-Danlos accompanying AN, with Ehlers-Danlos really serving as that maintaining factor for the anorexia nervosa. And one case report also describes spontaneous pneumomediastitum, so air within the chest cavity in patients with AN due to comorbid Ehlers-Danlos. Again, I should have said this before, but Ehlers-Danlos is a collagen vascular disease. Collagen is a tissue, or it makes up all the tissues in our body. So if that tissue is not healthy, again, these patients are at risk for these complications and as an explanation for the symptoms they experience. So takeaways, Ehlers-Danlos patients can be very difficult to treat because of the physiologic abnormalities that come along with Ehlers-Danlos, again, that slowed gastric emptying, that functional disease, the irritable bowel syndrome, and then there's a high prevalence of psychiatric disease, anxiety, depression that are prevalent in these patients as well. We are sort of able to sift through, does this patient probably truly have Ehlers-Danlos? Are these physiologic changes from the malnutrition? We're sort of able to start that process and get them started on the appropriate nutrition. Our experience is that these patients often require tube feeds just because of the significant GI symptoms they're experiencing. So again, we can sort of sift through those and get the patient started on the right path to treatment. Case study 6, eating disorder, diabetes mellitus type 1, previously known as diabulimia. So a 23-year-old female with 8-year history of ANR, type 1 diabetes, currently less than 60% ideal body weight, presenting from home for medical stabilization. She feels she does a very good job of managing her blood sugars with her pump, although her last A1C was 9.3, which would put her 3-month sugar average a little over 200, which is significantly above goal. States her pre-meal sugars run in the mid-100s, but she does not check her post-meal sugars. Denies any intentional insulin manipulation and also denies a history of diabetic ketoacidosis. I'll explain what that is in a second. Looking at her vitals, again, what you'd expect with the low blood pressure, the low heart rate, very cachectic appearing. Labs, again, seeing the low white blood cells, hemoglobin, and platelets. Mild low sodium at 134. Low phosphorus at 2.5, which these diabetic patients often appear to be at increased risk for. Again, insulin is a driving factor to push that phosphorus within the blood cell, or within the cells of the body. And her blood sugar, when she first arrived, was 209. 4 hours later was 439, and then the next morning was 47. So we're seeing a huge range of blood sugars, 47 all the way up to 439 over the course of about 12, 18 hours. So eating disorder type 1 diabetes mellitus type 1. Every patient that comes to acute gets an endocrine consult. Sugars can be very difficult to manage, as you can see from that range we just showed, especially as you're starting them on nutrition and titrating that nutrition to get the appropriate weight trends. Someone with blood sugars of this wide of a range would be considered a brittle diabetic. The most common cause for brittle diabetes is gastroparesis, and indeed these patients with malnutrition are high risk for that slowed gastric emptying, and diabetes is also a common cause for gastroparesis. So these patients are at risk for that slowed emptying for more than one reason. Behaviors, oftentimes it can be difficult to discern if the patient is truly manipulating their blood sugars. The reason we asked about that diabetic ketoacidosis when they first came in was to discern whether there was a potential manipulation. Diabetic ketoacidosis happens when there's intentional withholding of insulin. When you do that, your body starts to, instead of using carbohydrates, break down fats for nutrition, and so it's a way to lose additional weight. And again, these patients can be very sneaky, intentionally omitting insulin, underdosing, injecting medications other than insulin. et cetera, et cetera, et cetera. So when these patients first come in, they are not allowed to use a pump. We make sure they are getting the appropriate insulin at the appropriate dosing. And the scary thing about ED-DMT type 1 is that there is a 17-fold increased risk of mortality compared to those with just diabetes mellitus. And there's a 7-fold increased mortality compared to just solely those with anorexia nervosa. So you're sort of dealing with a double whammy here. So the takeaways with this case, not a good combination. You want to make sure these patients are being started on the appropriate insulin dose while you're titrating their nutrition. We don't allow insulin pumps early in their stay, and whatever facility or provider this patient's being discharged to, we will work with them to find out what sort of a regimen they would like them to be on, whether to resume their pump prior to sending them there. And we're going to be able to really better fine-tune their nutritional needs and their insulin needs just because of the way our unit is set up. Case study 7, medical versus psychiatric. So 33-year-old female with a diagnosis of ARFID, questionable anorexia nervosa binge purge subtype, presenting at about 90% ideal body weight from a residential treatment center due to ongoing vomiting of unclear etiology and significant tachycardia, having previously been diagnosed with POTS, postural orthostatic tachycardia syndrome, and needing frequent trips to the ER for IV fluids. She claimed that she was nauseous at all times without any associated abdominal discomfort. The vomiting would tend to occur within 30 minutes of any food intake, although occasionally she would vomit without any preceding intake. She did use daily marijuana, but previous discontinuation for several weeks did not result in any improvement, and hot showers did not alleviate symptoms. I'll talk about that combination in a second. You're probably scratching your head. Regarding the tachycardia and the POTS diagnosis, she reports going to the emergency department every 2 to 3 days for IV fluids. She had recently been started on diltiazem, which is a medication to slow your heart rate, and fludrocortisone, which is a blood pressure medication to increase your blood pressure. Because of that fast heart rate, the low blood pressure, the POTS syndrome she'd received, even though she continued to experience passing out when standing too quickly. So the nausea and vomiting, again, our unit, given the medical facility that we are, we reviewed the prior extensive workup that she'd had. We decided that an upper endoscopy was warranted based off her symptoms to make sure there were not any anatomic issues contributing to her vomiting. That was unremarkable. We thought anxiety was a big contributor to her symptoms, so we started her on anxiolytics. And we started her on tube feeds, and curiously, the emesis had resolved after about 3 days of tube feeds and that 24/7 bedside sitter, where she was unable to therefore participate in any purging behaviors. So she was diagnosed with a behavioral etiology, and she eventually admitted that she did have a bad eating disorder. We were able to convert her back to just oral nutrition with mandatory fluids, and at that point in time, with the increased fluid intake and the lack of vomiting, the POTS diagnosis disappeared. And in doing such, we were then able to discontinue her fludrocortisone and diltiazem as they were unnecessary. The hot showers and the marijuana use, anytime someone comes in with this non-volitional vomiting, we want to make sure this is not cannabis hyperemesis syndrome, which is a syndrome where as you use more and more marijuana, you actually, instead of having that calming and improved nausea, you actually develop worsening nausea and vomiting. And these patients tend to improve their symptoms with hot showers, hence why we asked that question. But with this case, again, it's differentiating because of the extensive multidisciplinary unit that we are. We were able to quickly define that this was truly volitional in nature. We were able to diagnose her hidden eating disorder, and we were able to sort of make some medication changes and fine-tune the medication list because these medications were no longer warranted based off this information. Case study 8, medical versus psychiatric, part 2. 25-year-old transgender male with a BMI of 26, putting him at 117% ideal body weight, who was referred from an eating disorder treatment center due to multiple episodes of passing out. He stated he had been purging up to 60 times daily and had been diagnosed with dysautonomia that had contributed to his syncopal episodes. Originally, the dysautonomia was controlled on medications. Again, that fludrocortisone, similar to what our last case was taking, and midodrine, which is also a medication to boost your blood pressure. But with ongoing purging, his symptoms again worsened. Upon further questioning, the dysautonomia was diagnosed in 2018 via a tilt table. At that time, he'd been on several medications that are known to drop the blood pressure, which we'll come back to in a second. But also again said that if he was able to maintain adequate fluid intake, his symptoms were largely unresolved. If we look at his medications more closely, the underlying medications, clomipramine, prazosin, Seroquel, these are all medications, and he's actually on pretty high doses of prazosin and Seroquel that are known to drop the blood pressure. And those medications in bold, benztropine, fludrocortisone, and midodrine, are actually medications he was started on to combat those side effects from the underlying medications. So we sort of had the belief that this was all polypharmacy, a lot of medications that were causing him to pass out. We started to cut back on the medications given the cardiac monitoring we're able to do on our unit. And he actually did well with this, and we were able to start titrating off the medications used to combat those side effects as well. So we were again able to differentiate, is this medical, is this psychiatric? We were able to start deprescribing some of these medications he was started on via discussion between the internist and the psychiatrist on our unit. And we were able to stop some of those medications that were treating side effects for the other medications. Case 9, MAI. So as I stated at the beginning, we don't just do eating disorders, we do malnutrition from other causes. So MAI, Mycobacterium, it's a cousin of tuberculosis. So this is a 41-year-old male with a history of orthorexia with extensive weight loss over the last 2 years. Had lost approximately 70 pounds, coming in at about 74% ideal body weight, but with significant swelling, diffuse edema throughout his entire body that had developed over the last few weeks. He denied a desire to have lost all of this weight, but medical workup back home had been unremarkable. And he had also been struggling with hypoglycemia over the last year, frequently reporting sugars into the 40s. On exam, again, significant edema in his lower extremities as well as his upper extremities. Glucose was extremely low at 22. Potassium, that should say 2.5, not 25, so potassium was also low. And curiously, his albumin was 2.2. Albumin is the main protein that circulates in our bloodstream. It does not correlate with level of malnutrition. So when you see low albumin like that, you need to start thinking, is there some sort of autoimmune? Is there some sort of infectious process? What is causing this albumin to drop? Because it's unlikely to be the malnutrition itself. So we did a chest x-ray on this individual, and it incidentally found several cavitary lesions. We did a CAT scan of his chest to further investigate that x-ray. And ultimately, he was diagnosed with this Mycobacterium, this cousin of tuberculosis. Consulted ID and pulmonary. He was ultimately started on a 4-drug regimen that these patients have to take for greater than 12 months. As I said, this is a cousin of tuberculosis. There's increasing thought that this may be related to eating disorders, this MAI infection, and it's starting to be studied a bit on our unit. What's important about MAI is that mortality significantly increases once your BMI is 15, and this individual actually had a significant low BMI once he had been diuresed. And the other concerning thing again with that, the Mycobacterium was clearly the cause of this low albumin. And MAI is a very hypermetabolic condition. This individual was requiring 5,200 calories at time of discharge. Trying to achieve that number of calories at any other facility can be very difficult. Looking at our other cases of Mycobacterium that we've treated, the average discharge calories is close to 5,500, and that's with a height of 5'5". So these patients are on extensive nutritional requirements. And like I said, albumin doesn't seem to correlate with BMI. So these patients with low albumin, they are at risk for pseudobarter, and we saw that with this individual with the significant swelling in his legs. And the other takeaway, again, is the nutritional aspect for these patients. Huge number of calories can be very difficult to achieve outside of acute. Last case, adolescent. A 16-year-old male with a history of selective mutism that had started about 6 months prior to admission. Autism spectrum disorder, obsessive compulsive disorder, and dysthymia, who presented at 66% ideal body weight based on his prior growth charts. Disordered eating had started when the brother began playing sports and paying more attention to his nutrition. There was a family history of celiac disease, and indeed this patient had tested positive with antibodies, but he had really never complained of any GI symptoms to his parents. His struggle to complete any oral nutrition was in part due to food sensitivities, and upon developing low blood sugars, a feeding tube was required on our unit. Pediatric neurology was consulted to rule out any organic etiology to his behaviors with that selective mutism. He did have quite an extensive workup on our unit, but ultimately it was diagnosed with basically behavioral etiology along with the autism spectrum. We do have a child life specialist on our unit. These are trained professionals who help patients and families cope with illness and hospitalization. They do provide psychosocial support, play opportunities for the patients. It can be very difficult to be in the hospital 24/7, especially during times of COVID, and emotional support. And our dedicated occupational therapists are able to really work with this sensory processing that's frequently in these autism spectrum patients and try to work on ways around that. So his hospital course, he did require a feeding tube during the entirety of his stay. Again, that food sensitivity with the autism spectrum sort of prohibited us from getting significant orals into this individual. He was discharged at about 90% ideal body weight to an outpatient team because of the struggles we were finding in placing him at any inpatient psych or other facility. Neurologic workup, again, very extensive, all came back unremarkable. There was actually the possibility that he may have had juvenile Parkinson's, which is an incredibly rare diagnosis. And there was a recommendation to perhaps try some medications for that, but the family opted against at that time. He did increasingly engage with our treatment team, but he remained very nonverbal during admission. So takeaways with this case, again, we can admit 15-plus-year-olds, no upper limits to our age limit. We do have access to pediatric specialists. We have access to child life specialists. Our occupational therapists are really able to help with the sensory processing that's present in a large population of these patients this young with eating disorders having that autism spectrum. And our room-based care is actually quite beneficial for these individuals with the autism spectrum, just because they, again, have less of that sort of sensory stimulation. And although we don't do family-based therapy on our unit, given that we're a medical stabilization unit, we are still a significant family involvement in the adolescent care. So discussion, again, medical complexities of severe extreme eating disorders are best treated in a medical stabilization unit such as ours that provides comprehensive care. We have appropriate and necessary medical oversight by medical doctors trained in eating disorders, along with psychiatric and nutritional support. Treatment in a med-surg facility can lead to further deconditioning. Oftentimes, again, these patients become bedridden with their med-surg hospitals. Oftentimes, these patients are going to receive inappropriate surgical interventions, as we talked about. They're not going to be treated by individuals that know eating disorders. So again, we are the experts in this field. The admission process, very cut and dry. Our intake specialists obtain the necessary information. We're not doing an entire biopsychosocial, just because oftentimes when they're needing our unit, it's a much more expedited process. And myself and Dr. Mailer are available for consultation for patients that we are trying to get to our unit and after they leave our unit, with the caveat that, again, we're not actually seeing the patient at those points in times. As commented on from a question during the last presentation, we do have that ability to transfer via air ambulance. And COVID has not really slowed things down for us. We have an extensive protocol workflow in place where we are screening patients. We have not had a single patient test positive for COVID on our unit at this point in time. All patients are required to be tested prior to admitting, or if we're unable to get that, they will be tested on arrival. And then we do extensive screening questionnaire prior to their arrival on our unit as well. Private hospital rooms are further going to lessen that risk. They're not, in the group setting. So we have a lot of increased capabilities of treating patients during these difficult times of COVID-19. That's the presentations.